Okay, it's
Oh,
working.
it's working.
Okay, we'll see. It's still telling me it's running, but I saw it said on the. If you're watching us live stream on Facebook, hang in there as we're sorting out our technology issues here, and we'll get started. Let's see. I'm gonna pop into Facebook and see if I see us over there yet. Oh, yep, we're on. We're great. This is fantastic.
Great.
Okay, I am going to resume the recording. Perfect. Welcome, everyone. Thank you so much for being patient while we got all of our technology set up. As I was telling our guest speaker today and some of our guests that joined us on Zoom, I'm a Gen Xer, so sometimes the technology takes a little bit more effort for me. But thanks for hanging in there. Welcome. We've had a series of webinars in the past called Ask the MFM, the Maternal Fetal Medicine Specialist. And we're super excited today to have our series now, Ask the Cardiologist. As many of you know, at least in the US, February is American Heart Month. So we spend a lot of focus on heart health. And of course, in our group, we talk a lot about uh, pregnancy and women's heart health. Um, and it was just super fitting for us to have this conversation today. Dr. Maria Paban is actually one of our Aspire board members for our group. She helps us, along with a number of other patients and clinicians in different specialties, gives us guidance on how endpreeclampsia.org and our group here, Preeclampsia, Eclampsia, and HELLP syndrome survivors, global support network. Whew, it's a lot of words.
Mhm.
That's how the algorithms on Facebook work. Um, how we go forward and what kind of research and evidence based information we make sure that all of our members are aware of. So we're really excited to have her here today. Again, we're at the Ask the Cardiologist webinar. I would love it if you post a comment either in Zoom if you're logged in there or on our live stream and let us know where you're logging in from. We'd love to know where you're coming in from. If you have questions, feel free to post them either in the Zoom chat or on the live stream. I will do my best to get to them. We'll have some question and answer at the end of our talk here today. We have a bunch of questions that were pre-submitted, so we're going to try to get through those. And I imagine probably a number of the questions you might have, Dr. Pebham will answer perhaps for us anyway. Great. I see you guys are already posting Tacoma,
Oh,
Washington,
amazing.
Canada, Puerto Rico, Naples, Florida, Alberta, Canada. Yay, fantastic. Welcome,
So
welcome,
good.
Pennsylvania, Europe, Minnesota, Pennsylvania. Fantastic. So exciting. Okay, so just a couple of housekeeping tips before we get started here. I want to mention a couple of things. First of all, we don't really do trigger warnings in this group because there's so many things that could be a trigger to anyone. But I do want to just sort of make a statement that while the stuff we're talking about today is scary and can be scary, this webinar is really meant to be empowering. It's to provide education, information, to see what's going on in research that can impact us positively. We're going to answer a bunch of questions that you have about how to reduce risk factors. And so I just want to kind of start off the call here, putting that out there that we hope you take away today some empowerment from this, some education, some information, and not that this is a fear, sort of fear-mongering situation. We're here to empower you to reduce other risk factors and to understand how to take care of your health. So I just kind of wanted to start on that that topic there. Hopefully we are, can everyone see? Oh yeah, I just want to make sure that the live stream is working and the Facebook looks like it's good. Okay. The other thing is, I want to mention that Dr. Pavan is not your clinician. She is not going to be able to diagnose or treat or provide personalized medical advice to anyone in particular. So all of the answers to questions are going to be generalized based on just a little bit of, information that we're receiving in the question. So take her answers as general information that you can take back to your care provider who treats you, who knows your, medical history and chart, and ask questions of your care provider, or seek out a care provider who can provide you with care. And if you're in the greater Boston, Massachusetts area, you can probably book an appointment with Dr. Pavan so she can be your clinician. So just some of that housekeeping. So we will do some introductions here, and then Maria is going to provide us some fantastic information, and then we will get to some Q&A at the end. So introductions, I am Kara Belt. I'm the founder of endpreeclampsia.org and the Preeclampsia, Eclampsia, and HELLP syndrome survivors group, where many of you are watching this live stream. I started this effort after my own personal experience with preeclampsia at 31 weeks, many, many, many years ago. I have a college student now. And I realized there just wasn't really much patient accessible information online. And in the years and decades following my preeclampsia and HELLP syndrome experience, we had some, further research happening. And one of those, was a bunch of research to get to the point where the American Heart Association actually came out in 2014, I believe, and said, kind of very unprecedented, said, hey, there in fact is an additional risk factor for cardiovascular disease. Preeclampsia is a risk factor for cardiovascular disease, and this is something we need to to recognize. Now we know it takes sometimes decades for that information to trickle down into general patient care. And I think that many of the questions we have today are because a lot of that information isn't in the hands of our primary care providers, or even some of our generalist OBs. So we're excited to learn more, to engage conversations, for you to have those conversations with your care providers, and for us all to be a little bit healthier. I'm going to let Dr. Pelban introduce herself, and then we'll let her take it away. Thank you for joining us.
No, no, you're welcome. Thank you, Kara, for inviting me. I love Preeclampsia. I met Kara when I was a fellow, actually, a few years ago. It's been a few years already, Kara. That's crazy. Yeah, I'm passionate about women's cardiovascular health, and especially about how pregnancy complications can affect, heart disease in the future. I am originally from Colombia, and I did my medical school there, actually. And I moved to New York City to do my residency. And then I did my fellowship here at Brigham and Women's, where I stayed as a cardiologist. And I work most of the time, actually, I do research. I do mostly research, but I do have once a week a women's health clinic, and I also see patients in the hospital. Most of my patients are either pregnant women with heart disease, or pregnant women that developed heart disease during pregnancy, or women that are looking for a preconception evaluation. Also, women that have had a history of a complication during pregnancy that come in for a prevention visit. And then also a lot of women with established heart disease, that we can talk in another time, but there's certain types of heart disease that are more common in women than in men. And so a lot of my patients have those conditions. But yeah, that's a little bit about me.
So what drew you sort of specifically to taking care of the hearts of pregnant patients, or surrounding pregnancy?
Yeah, so I think it all started when I started my fellowship. I had no idea I wanted to do this because I just never thought about it, to be honest, until when I was doing my fellowship, I learned first that first of all, it was shocking to me that during my residency, I just didn't know how much pregnancy affected cardiovascular disease. And this is like, my internal medicine program was amazing. Like it's one of the top in the country. And even so, I just had no idea. And then, how different cardiovascular disease presents in women than in men. And even though it's, the number one killer in the US, like people still don't think about it that way. And even as when I was a primary care, doing primary care during my residency, I just felt like I just didn't have this knowledge, before. And so that's how I started getting interested. And then when I started learning more and more about it, it was fascinating to me. And then when I was a fellow, I used to get consulted by the OBGYNs, when pregnant women came with shortness of breath or chest pain. And then then I started getting into like how pregnancy can affect your heart. And that was also fascinating to me. Again, had no idea. And so all of that just led me to just be like, okay, this is what I want to do forever. So yeah, so it started with ignorance, literally, just like just being shocked at how little I knew, even though I was a doctor that had already specialized in internal medicine and in a good academic program. And even so, I just really had no idea.
Well, and I think that's probably what a lot of our patients come across, right? Like really great physicians who just don't have training in that, in part because it's probably understudied and underfunded and all of those
Absolutely.
obstacles. So, um, great. I mean, we're so happy that that you sort of fell into this because we certainly, our population certainly needs you and the research you're doing. So we're super grateful for that. I will let you go ahead and
All
get
right.
started.
I'm gonna share some slides. Thank you so much for everyone that sent the questions.
Yeah, we.
I yeah, I this was basically I targeted this presentation. This is literally like these slides were done for you guys. Like I've never presented this before. So this is brand new presentation for Preeclampsia based on the questions that you guys sent. So hopefully you find this helpful. But obviously happy to answer any other questions that weren't covered in this slides. So let me start. All right. So, oops. And I apologize, I was taking care of my computer is going nuts today, but hopefully it behaves. But so yeah, so what I was kind of alluding to before, right? Cardiovascular disease is the leading cause of death in the US of women in the US and worldwide. And even though, there were a lot of efforts around, the 2000s and even the 1990s on how to reduce cardiovascular disease, as you can see in this graph, um, it actually it turned out that it actually led to some decrease in the mortality of heart disease. However, after like the 2010 or so, that kind of plateaued and stagnated, and mortality has kind of remained untouched over the past few decades. And then also, the cardiovascular disease mortality is increasing among young adults and midlife women. And so that led us to think, okay, so we've done a lot to obviously work on how to decrease cardiovascular disease mortality, but maybe we haven't done enough to address it in 50% of the population of the world, which are women, because we don't really understand well how sex-specific mechanisms in cardiovascular disease can affect the risk of women, right? And so one of the sex-specific risk factors is hypertensive disorders of pregnancy, which a lot of you are familiar with. Um, and why is that? Pregnancy is, one of the most extraordinary transformations that the human body can undergo. Your heart, your blood vessels, your kidneys, they don't just work harder, they completely rewire their pathophysiology to support you and your baby or babies. So you can think about it as like an athlete that train for the most intense marathon, but without actually consciously doing anything, right? Like your body just knows how to adapt. And so your body increases its blood supply by up to 1.5 liters. And just so you know, like the amount of blood you have, it's like around 4 to 5 liters, depending on people's sizes. So 1.5 liters increases a lot. It's a significant proportion of what you normally handle inside your body. Your body's decreases the blood pressure by 30 to 50%. Your heart rate can increase by 10 to 20 beats per minute. And there's like about a 30 to 50% increase in your cardiac output. This is basically how hard your heart works during pregnancy. And what this means, an increase in cardiac output by 30 to 50%, you can think about it as like running a low intensity workout training for 9 months straight, like with no rest. And so you can imagine this is like a significant challenge for people's hearts,
Like
right?
when
You
you're
have to
sleeping,
handle,
right?
yeah, exactly.
Mhm.
Exactly. Even when you're sleeping, like you're handling extra volume. So your blood vessels basically kind of just relax and kind of open to receive these extra amount of blood that your body is handling. And then note that these changes are even higher in twin pregnancies. So some of you, I imagine, had twin pregnancies, and for those of you, you were even handling higher changes than what I'm presenting here. And so, for most pregnancies, this adaptation goes smoothly. But for some women, the body struggles to fully make these changes, particularly in the setting of preeclampsia. The body gets troubled by relaxing the blood vessels without and regulating the blood pressure, basically. And so, for example, in preeclampsia, instead of relaxing properly, the blood vessels stay kind of tight, and it makes it harder for blood flow to go smoothly. And, that can lead to problems for mom and for the baby as well. And just a reminder of the definitions of hypertensive disorders of pregnancy. I know that I've met quite a bit of you, so I know a lot of you are experts in this field, but just in case you are not one of those, there's different types of hypertensive disorders of pregnancy. They're classified usually based in whether you had high blood pressure before 20 weeks gestation or after 20 weeks gestation. And so if you developed high blood pressure before 20 weeks gestation, we usually call that just chronic hypertension, meaning even though if you didn't have a previous diagnosis of high blood pressure, most likely you did, you just didn't know. And so that's why before 20 weeks, we think this is mostly, something that you've been dealing with and just people didn't realize. Because as you know, like, when you're healthy young women, you don't really go to the doctor that often. It's just what happens. People are busy and lives are busy. So people don't go to the doctor once a year, even though, most people try, it's hard to fit in the schedule. So some people just don't know that they have high blood pressure to begin with. But some people, they never have high blood pressure and they develop it after 20 weeks. And if that happens, then we call it gestational hypertension or preeclampsia, depending on whether you have other organs affected or not, basically. And they seem to be separate things. They seem to be different kind of diseases and that are, developed based on different pathophysiological mechanisms. So it is important to sort of have that distinction, I think. And then there's obviously, the eclampsia patients, and then you can have chronic hypertension and then develop preeclampsia, and that's what we call superimposed preeclampsia. And so those are sort of some of the terminologies you may have heard in the past. Um, Hypertensive disorders of pregnancy. So all of these are the leading cause of maternal mortality and infant maternal morbidity and infant morbidity and mortality globally. So super important thing for us to target to make sure to prevent them and know how to treat. And then hypertensive disorders of pregnancy, besides that, we know that obviously they complicate pregnancies for mom and for babies. They are not all about pregnancy. They're actually a clue about future heart health. And it just tells us that the cardiovascular system might be more vulnerable later in life, which is why we use these hypertensive disorders of pregnancy as an early warning sign to take preventive action. So as Kara said, it's not about like making people scared, it's about you can do something about it, right? Like this is your body telling you, okay, you may be at risk for heart disease, let's do something about it now.
Dr. Bowman, where does, because we'll have a number of people who had HELLP syndrome and they may have had sort of HELLP syndrome without the preeclampsia, increased, blood pressure prior. Do you lump HELLP syndrome in this group as well?
I do. I
Oh,
do in the sense of it being an early sign for making sure that we,
okay.
really do aggressive prevention for heart disease. And this is because HELP syndrome, and I'll show you, one of the hypotheses of why, hypertensive disorders of pregnancy are associated with heart disease in the future. And one of the hypotheses is that there's these molecules that are released by the placenta that kind of go everywhere in your body and sort of damage this really tiny blood vessels that exist everywhere in your body. And so that happens with HELP syndrome too. And so even if you don't have elevated blood pressures, so I do take it as a risk factor as well.
Great. I just didn't want to leave our HELLP syndrome folks out.
No,
I know they'll have questions.
perfect. And yeah, please feel free to interrupt me all the time. Again, this was based on your questions, but if you guys need more clarification about specific slides, just we can stop. All right, so what type of heart disease have been associated with hypertensive disorders of pregnancy? So a lot. I added one here because I think it's the one that people think about the most, which is chronic hypertension. So patients that have had a hypertensive disorder of pregnancy are at 4 to 6 times more likely to have hypertension 5 to 10 years later after the event. And so that's kind of the one of the most common ones that I think most of you are familiar with. Um, the risk can be higher if there have been multiple pregnancies complicated by hypertensive disorders of pregnancy, and I'll show you that in a second. But just wanted to highlight that, that there is like a broad spectrum of heart disease, right? There is high blood pressure, but there's also, coronary artery disease, which is basically what leads to getting heart attacks, heart failure when the heart is weak or when the heart doesn't relax well, and patients have trouble breathing and trouble with their kidneys. Valvular heart disease is another one. So something like aortic stenosis or mitral regurgitation. And so the risk, varies, and it obviously everybody is different. So it doesn't mean that if you had preeclampsia, you have 6 times more likelihood of getting hypertension, but it means that on average, people that had preeclampsia have that risk of hypertension. So as I said before, and this was one of the questions that came up, and I think it's a really good question, is um, what happens if you have more than one pregnancy complicated by high blood pressure? And so the answer is that having high blood pressure in pregnancy, especially if it happens more than once, can increase the risk of future heart problems. And so, for example, here on the left, this is a graph that just shows you, for example, the risk of having gestational hypertension once versus twice. So even though it's a modest increase, there's definitely an increase. And same for people that had preeclampsia. So people that had preeclampsia had 1.65 times higher risk of developing heart disease in the future, sorry, chronic hypertension in the future. Whereas if you had preeclampsia twice, this increases to 2.23. And so it is a modest increase, but it is a significant difference. And it may not be, this is where we kind of have to differentiate what it means in epidemiologic studies and what it means for you, right?
Right.
So what it means for you is a slightly higher risk for you, but this can compound with other risk factors you have, right? So that's why it's important to just kind of know your facts.
Right.
What about, mhm,
So this chart doesn't say don't go and have that second or third baby that you really want. It just means it if you have preeclampsia again, or gestational hypertension again, there's a modest increase in that risk for heart disease. But and you should talk to your own physician about that. For many of us, it's perfectly acceptable risk to build our families. And if you have some sort of existing heart disease, that is maybe a more important conversation to have before you have that next pregnancy, right? Again, we don't want people to walk away and be like, "Oh, my risk is so much more. I'm not gonna try for that next baby." You're not saying that. There is an increased risk, and I think this was one of the most frequent questions that we received. I want to have another baby, but I'm worried about my heart health. So
absolutely.
there is an increased risk in those additional pregnancies if it's complicated by a hypertensive disorder of pregnancy. And that's not a given. Just because you've had it before doesn't mean you will get it again. In fact, the risk is actually relatively low in subsequent pregnancies.
Correct.
And it's something, to talk to your doctor about.
Absolutely. The risk of recurrent preeclampsia. And again, these are different studies and studies. Most of these studies are epidemiologic studies. And what I mean epidemiologic studies, a lot of it is basically looking back into, people reporting things or how or diagnoses that were put in patients' charts. And so the studies have limitations. But again, you have to kind of extrapolate this data and think about how can this help you rather than meaning, you will definitely have a heart disease, you know what I mean? Um, yes. So, and we'll discuss a little more on how to, because everything basically compounds, right? Like your other risk factors for preeclampsia compound with, your risk factors for cardiovascular disease. And so it really depends on you specifically. And that's what Kara, I agree that it's very important for you to talk to your physician because it's like different parts of the puzzle and the outcome is going to be different for each of you, right? All right, so how are these two things linked? Why are hypertensive disorders of pregnancy linked to future heart disease? One of the hypotheses is that hypertensive disorders of pregnancy and heart disease just share many of the same risk factors. Some of you may know, preeclampsia risk factors include high cholesterol, high blood pressure before pregnancy, an elevated weight. So all of these things we know are risk factors for cardiovascular disease, and they're also risk factors for preeclampsia. And so it is possible that they just share common risk factors. But other hypotheses include that hypertensive disorders of pregnancy causes damage to the blood vessels that can just kind of persist for decades and decades and just lead to heart disease. And so this is what I was telling you about that in preeclampsia, the placenta just gets really stressed out because it's not getting enough blood and enough oxygen. And so it releases these little molecules that go everywhere in your body and lead you to have, all of the complications that some of you experienced. And so that one of the hypotheses is that maybe some of these molecules kind of stick around and just damage those vessels and they just don't recover. And that leads to heart disease. Additionally, hypertensive disorders of pregnancy can cause strain on the heart because remember, your heart's already working harder. And so if you, on top of that, in a normal pregnancy, and then if you, on top of that, add high blood pressure, your heart works even harder. And some of it just can, strain the heart and that strain can just kind of persist over time.
We
That
we get so many posts within the support group about women feeling guilty or that their bodies failed them, and I always tell them, in fact, your body didn't fail you, and you just mentioned it, right? That placenta didn't, your body didn't fail your baby. That placenta did everything it could, right? It released all these molecules, these sort of chemical proteins out to try to get more blood, to do what it needed to do, to the point that it was damaging and harmful to you, mom. to support this baby or babies. And so you didn't fail, like you actually, took one for the team. And that of course is a harder conversation when you don't have a good outcome, certainly. But know that your body did try to do everything it could to support that pregnancy. So
Yeah, bodies are just incredibly resilient and just, it's amazing what your body can do. And I totally agree. Your body does it does its best. It just gives it all. And also, even if you think about it, like, okay, let's say that, I have some risk factors. For example, I'm overweight. That doesn't mean that because you're overweight, you got preeclampsia, right? Like, there's just so much more that we don't understand. And we know for a fact it's a lot of genetics, right? And like, how are you to be blamed for your genetics, right? Like, there's nothing we can do about it, right? So all we can do is just, again, just do our best to take our information and do the best we can, right? So thank you for pointing that out, Kara. All right, so now the most important thing is I had preeclampsia. What can I do? And so basically, again, we're talking about how this little increased risk on, you know, your increased risk for heart failure, your increased risk for coronary disease, they kind of compound, right? So all the things that we know that can also affect the heart are your nutrition, your exercise patterns, do you sleep well, right? And so you're already dealing with a little bit of increased risk from your complication during pregnancy. Then all you can do now, you can't change the past. That already happened. All you can do now is focus on the future. So what are we going to do to decrease your heart disease risk? And so the American Heart Association actually released, and this was, I think, 1 or 2 years ago. This is pretty new. It's called the Life's Essential 8, and it's basically recommendations based on the current research that we have available on how to decrease your risk for heart disease. And I created this QR code in case you guys are interested on looking at the website, because the website was actually designed for patients. And so it's completely like, understandable, has specific recommendations, even it has recipes like for healthy diet. And so it has a lot of information. So highly recommend that you give it a try and just kind of explore around. But we're gonna talk about each of these and what are like some of my tips when I see patients that I tell them. So some of it is, eat better, be more active, manage blood sugar, manage weight, control cholesterol, manage blood pressure, quit tobacco, and get healthy sleep. So we're going to talk about each one of these in
before we
particular.
move on, I think there's two questions in the chat that
Mhm.
are somewhat relevant to this, but also to the different types of hypertensive disorders of pregnancy. And maybe you're going to cover this, and if you are, that's fine. Um, if you have postpartum preeclampsia, meaning you didn't have preeclampsia before or during delivery, but you developed it in that sort of 6 weeks after, what does your risk look like? Is it comparable to gestational hypertension? Is it comparable to just regular preeclampsia had you had it during the pregnancy?
Regular preeclampsia, yeah. So within preeclampsia, actually, the risks varies, and so there is preeclampsia, and there's preeclampsia with severe features, and then there's also preterm preeclampsia and term preeclampsia. And so we know that all of those are spectrums of preeclampsia. Most studies have just kind of lumped all of these together, and so the most of the risk, the risk that I showed you before are including postpartum preeclampsia, preterm preeclampsia, term preeclampsia, preeclampsia with severe features, preeclampsia without severe features. And so it is hard to like know specifically like, how this varies based on the type of preeclampsia you had. But what we do know is that preterm preeclampsia and preeclampsia with severe features seem to have a higher risk than term preeclampsia or postpartum preeclampsia. But in most studies, we don't really understand yet how those are how different those are in terms of future cardiovascular risk. But this is sort of what we know. But all of these were kind of lumped in one.
Yeah, I know the obstetrics folks have been pushing hard to, to do studies that, and I think we all sort of believe that there's enough evidence out there that these may be different, like you call them a spectrum, certainly, but some of it, they might be different diseases even. And that more research needs to be done. The problem is finding enough, pre 24 week or, postpartum preeclampsia patients to do a good quality study can be difficult, which is why they've lumped them all together. But I think what I heard you just say is if you had postpartum preeclampsia, meaning you never had preeclampsia during pregnancy or during delivery, developed it in that 6 weeks postpartum, you have a risk that's similar to had you had preeclampsia during pregnancy. Perhaps it's a little bit less risk factor or lower than, early severe, but you do have a risk, the same risk factor. Um,
Yes, exactly.
okay, great.
And in fact, I mean, there's a lot of things we don't know about postpartum preeclampsia, which to me is fascinating actually, because a lot of the preeclampsia patients I see is actually postpartum preeclampsia, because that's when, the pregnancy is over and then a lot of them come into the hospital and cardiologist is the one who comes to see them. And so, yeah, postpartum preeclampsia is fascinating to me. And that I think that's a topic for
Yeah, we'll do another
another
webinar.
talk. But yeah, I mean, some of them just come with like heart failure kind of picture, right? And it's very amazing because it kind of resolves within 5 days or 7 days, and people sort of retain fluid, and then they get treated, and then it goes away, and then we don't really know what happens. I mean, like, are these women at higher risk for heart failure than people that didn't retain fluid? I don't
Yeah.
know. We don't know. So a lot to be done for sure, in terms of research. All right,
All right, Annie,
so
go on.
yes. All right. So eat better. So eat better how? Like we all listen to, okay, you have to have a healthy diet. But especially, if you have recently had a baby, this can feel overwhelming, in my opinion. It feels overwhelming to me, and I don't have a baby. I can't imagine how it may feel to people that have to deal with, making sure that the family is okay, have a newborn, etc. And so I think the first thing is like
Or even having access to, you
to
know,
healthy food,
yeah, to healthy food or food in general, even.
food
Yeah.
in general. Yeah. And so I think the first thing that you have to think about when you're thinking about how to decrease your cardiovascular risk is that, first of all, you're playing the long game, right? So there's no need for you to just like go crazy obsessive about all of the things I'm going to tell you. It's more about how little by little you can take small steps, and those will compound to prevent your heart disease in the future. And then second, in my opinion, perfect is the enemy of good. Some people are like, oh, well, I broke my diet today, I'm done. That's okay, like I break my diet all the time. But then you just try your best. I think that's I think if there's a message that I want you guys to take home is just do your best. It's okay if it's just a little bit, especially if you just had a baby, like just have some patience and be gentle with yourself, right? Like you probably don't have time. Like I'm gonna tell you, try to sleep well. Well, I mean, that's kind of hard if you have a newborn. So just think about that. This is not to start right now, right? Like you can wait until things are a little more settled, and then just start thinking about, okay, when the baby starts sleeping the full night, I will do this and this and this to improve my sleep. It doesn't have to be right now, but this is something that you can start kind of making plans on how to modify it within the next few years. Okay.
Yeah, I always
And
tell
so,
people I was like, if you just start drinking more water every day, like that's a great first step, right?
yeah,
Because we, chasing kids and jobs and family and whatever else we have to do, sometimes drinking water, we can't even, accomplish that. So
exactly.
carry a water bottle with us, like that is an improvement. That's a good
That
step.
is an improvement. Yes, it's a huge step. And people think that is not, but I will show you in the exercise part that it is very important. And so what do we know about diet? So as you know, there's diet research is also very, very difficult, and people feel very strongly about different types of diets. And so I'll tell you what we know from research, and what we know from the literature is that Mediterranean diet is probably the best diet to decrease your heart disease risk. Okay. And the good news is Mediterranean diet, in my opinion, is also delicious. And so I think you have plenty of options, even if you don't eat meat, if you're vegetarian, there's options within Mediterranean diet that you can apply. And if it doesn't apply to you, if some of these that you don't like, choose what you can. And for example, somebody just posted what type of oil is best for cooking. Olive oil for sure. If you can use olive oil for everything, that would be for sure my preference, or Mediterranean diet preference.
And
Um,
also, if you don't have access to it, you can't afford it, it's not going to be the thing that, that it causes you to have cardiovascular disease, right?
Absolutely.
So it's just like you said, take what you can from this, baby steps, small changes can make a big difference.
Yes, just moving in the right direction is what matters. And so, for example, a few ideas that you can pick and choose, and that I think they're a little bit easier is try to, for example, to swap one thing at a time. So for me, like one of the easiest things to swap in diets are like juices or sodas, because I feel like drinking like a liquid is a little bit easier to like hold yourself and be like, okay, I'm not gonna have that Coke, rather than some like a burger, obviously it's a little bit more attractive. So, you can start with that. Just gonna start there. If you like soda, then switch to seltzer water. If you like your coffee with cream, maybe try almond milk. If you like juices, then maybe try to eat the fruit as a whole rather than like the juice. You can also try some portion control. So we do know that, even though calories, there's a huge debate about calories, there's something to say about sort of thinking about how many calories you want to consume a day, because then you start kind of paying attention to the labels, of what you're eating. And you can pay attention to the portions, because a lot of the times, some of you may have already experienced with this. Like I certainly did when I started at first to look at the portions. I was like, oh, I'm eating way more than a portion for this, right? And another idea is like buying one wise, if you can, a scale, and like weigh for a week, weigh what you eat. And so you can have an idea of like how much you're eating of each thing. And then, because once you do it once, then you kind of know you don't have to do it every day. Obviously, nobody has time for this, right? But if you do it once, you kind of have an idea of what the portion should be for you. Um, and then just try to like change, for example, if you do chips, then maybe swap for some nuts if that's something that's available to you. Nuts are expensive, I get it, so not for everyone. But fruits can be another good healthy snack. Hummus, so if you like veggies with hummus, are another good healthy snack. And then always just remember, no one really eats perfect all the time. No one does, and you don't need to. What matters is that you're making more heart healthy choices over time. And you will, I mean, you start with one thing, and then you start with another thing, and then you add another thing, and then that with time is what matters. Drink more water, super important. But everything, the compounding of everything is what matters. So don't obsess about having a perfect diet.
Yeah, I'm going to put in a little plug. We have a chat within the Facebook group, the Preeclampsia, Eclampsia, and HELLP Syndrome Survivors Facebook group, that's about heart health and healthy lifestyle. So if this is a good conversation for you, it's just a casual conversation where people are checking in with whatever their own personal goals are for, lifestyle changes or health, and that might just be drinking more water. Somebody in our group is, their goal is to exercise a certain number of times a week. Things like that. Feel free to join over there in the conversation. I think just all of us together working towards a goal. It's not high pressure, it's not like a weigh-in group or anything like that. It's just, to talk to others who've been there and we're trying to make these changes. I personally have lost 80 pounds in the last year and a half or so, and I did it, as you mentioned, I just started like tracking my food. and I still track my food, but I don't obsess about the calorie count, right? Like I know where I should be calorie wise. And if I'm hungry, I'm going to eat. And I just track it. So I know where I'm at. And I think that's given me maybe a little bit more healthy perspective.
Hmm.
Weight loss, it isn't like I have to lose. And if I don't lose, a pound this week, then I'm, going to go binge the Ben and Jerry's ice cream. It's just, making those small changes. And my personal goal is to eat about 80% healthy, because it's also like life. And sometimes you want the Ben and Jerry's, and that's totally
Yeah,
okay, right?
absolutely. Sometimes you want to order food or takeout. Sometimes you want to go to a restaurant.
Or yeah,
Yeah,
Friday
and
night,
that's normal.
you want pizza or whatever. So, uh,
Exactly.
yeah, I think just the theme here is progress, not perfection.
For sure.
Yeah.
All right. This is one of my favorite parts, and it's how to be more active. And I don't say it because I love to exercise. Believe me, I'm one of the laziest persons you will ever meet. I do try to go to the gym at at least 4 times, 5 times a week. And the reason is because I just realized that it's good for my mental health. Like my job is stressful, and so I take it. I view exercise as like the pill I'm gonna take. That's how I take it. And so even if I'm lazy about it, I'm like, okay, this is my medication, so I have to go. And that's how I find motivation for it. But you can find motivation in other things, and I'll tell you what you can think about. But again, exercise is not about perfection and is not about doing extreme workouts. It's about movement that makes you feel better and that supports your energy and protects your heart. Um, for example, again, if you recently just had a baby, your body is adjusting, you will not be able to go running. Like you will feel tired, and that's
Nor should
okay.
you, right? Nor should you. Yeah.
Nor should you, exactly. So, walking with your baby counts, dancing with your baby counts, stretching while watching TV counts. Um, Instead, thinking it as an exercise, as a task, think about it as a way to give back to your body, right? Like your body has helped you throughout all your life. And you don't have to, so the American Heart Association recommends 150 minutes of moderate activity per week. And if you think about it, that's not that much. Like if you break it up, during
It's
the days of
30,
the week.
yeah, 30 minutes, 5 days a week, or some other
Yeah, but you can even break it up. You can do 10-minute workouts during the whole day. So for example, you can say, I wake up in the morning, I do 10 minutes of walking, and then I do 10 minutes later, and then another 10 minutes later. That's good enough. Um, Even small amounts of movement add up. Things like I park a little bit farther so I can walk a little bit. I'll take the stairs today. Right? I often think about that. Like when I don't have a car in Boston, but I sometimes I'm like, oh, should I get an Uber or should I get the train? And I'm like, no, I'm gonna walk. It's fine. I'll call my mom. I'll catch up with a friend. It'll just be some time that I can just kind of include my physical activity there, right? Um, One
I
of the
love
things
that you can
people,
break it up throughout the day. This is where I struggle. The food I figured out, the exercise is a struggle for me. So I love that thought. Like, oh, I can take 10 minutes on the treadmill in the morning. I can take a 10-minute walk after lunch, and I can do another 10-minute walk after dinner, just to get started. If
just
nothing.
to get started, yeah. And then I wanted to show this because I think it's a little bit of an extra motivation. So obviously, both men and women benefit from exercise. But there was this paper that was published last year in one of the best cardiology journals that showed that women see better benefits with as little as 20 minutes per day of exercise. Obviously, doing more, like the more you do, probably the more benefits you have. But like, men, for example, in this study needed to reach about 300 minutes per week to see the same benefits that women saw with 140 minutes per week.
Yay.
So the odds are on your favor, just like even if it's just a little bit, it'll give you some benefits. So definitely go out and exercise or just stay at home and exercise. There's no need to go out if you don't want to.
And then you don't have to feel bad like trying to keep up with your male partner if you have a male partner, right?
Exactly. Exactly. All right. All right. So then it's next, I kind of put two together in how to manage sugar and weight. If here there's also no guilt and no shame, right? Like I feel like as women, we all have dealt with this all our lives. And so if managing your sugar and your weight feels overwhelming, again, know that small changes can make a big difference. And weight and blood sugar is just one part of your overall health. And so this doesn't define your worth or your success at all. And things that you don't think that can affect your weight or your sugar can affect your weight or sugar, like stress and exercise and stress and sleeping, you know? So definitely like it's not all about like I have to have a strict diet and like I cannot eat anything, or it's not about like punishing your body. It's more about like making small changes that can help, in the long run. And so we all know that keeping your blood sugar stable helps protect your heart and helps reduce systemic inflammation, like inflammation in all your body. But I think a good thing to do is just manage your weight in a way that feels natural and healthy to you. And this can help reducing your risk for diabetes, for high blood pressure, for heart disease. But one of the things I wanted to highlight, because I feel like it's underutilized, or I see it in my medical practice, is that seeking support is a sign of strength and not a failure. And so talk if you're struggling with weight loss, go talk to your doctor, because now there's doctors that actually specialize in weight loss, like this is literally all they do for their life. So they're experts in this, right? And so there are weight management programs that you can join. There's medication options, there's surgical options. Some people are like, I feel like some people just put a lot of shame into using medications, or, do whatever works for you. Like, it doesn't matter if you do it with medications, with diet or exercise, with if you have to go to a clinic, if you get a surgery. What matters is what works for you. So I think that that's an underutilized thing that you and most, people with insurance will have access to weight specialist. So that's just a quick plug in.
Yeah,
Um,
I'm glad that you mentioned that. I think many of us, just anecdotally speaking, have possibly been, whether we were like weight shamed with a physician, right? And whether that was actual shaming, weight shaming, or just how we internalized it, right? Those are potentially two different things. But also, I think, at least as a woman who is closer to 50 than 40, um, I have found that, prior to my weight loss, whenever I had a complaint, a health complaint, it was like, oh, well, like you should lose weight and then we'll look into it. And I'm sure others have experienced that as well. And I am treated differently now that I've lost that, the amount of weight that I have, and yet I still have some of those same, issues, right? So I just want to encourage people, if you go to that physician, that care provider, and you're not getting the support that you feel, or you felt shamed, don't let that stop you from seeking out a better care provider who is understanding and who will, work with you and give you the support that you need. Don't just stop with one,
bad
clinician
experience. Yeah.
yeah, with a bad experience. There are, lovely people like you and others out there who will be supportive in these changes. So, don't let that stop you from, prolonging your life and getting the help you need.
Absolutely. It's like one of those things like if somebody tells you that there's a pill that can make you live 10 more years healthy, like wouldn't you take it? I'll take it. Absolutely, I'll take it.
Yeah.
So, don't and of course, I mean, there's obviously like people that prefer, like natural ways, and that's also okay. But just know your options. You have options and you should utilize them, okay? All right. Okay, so how to control cholesterol. I also love this one because as a cardiologist, we're obsessed with cholesterol. But just one of the things that you should think is, cholesterol is something that your body needs. It's just something that your body needs to exist. But there are different types of cholesterol. And so there's the two that I want you guys to remember is the LDL, which is the bad cholesterol, and then the HDL, which is the good cholesterol. And, they're not completely bad or good, but I wanted to say it just because that's how people refer to them. But you can think about the LDL as like a traffic jam in your arteries. And so too much LDL can kind of slow things down. And you can think about the HDL as like the cleanup crew that kind of helps clear out the excess of LDL. And so it's good to keep those in a good level. And I'll show you what the ideal levels for those are. And so what can you do? So first of all, make sure that you get your cholesterol checked because a lot of women actually don't. Because statins, which are the cholesterol medications, are you can't take them during pregnancy. And so a lot of doctors are like, well, I'm not going to screen women for high cholesterol because, they may get pregnant. And so what are we going to do with the statin? And it's not about that, right? Like you can always stop the statin if you're taking it before getting pregnant. Like I feel like you should know your risk and you should know your cholesterol levels. But obviously don't obsess about it because this tend to be highly genetic, highly genetic. And so it's also not your fault. And for example, a lot of the LDL is genetic. So even in women that, do their best and change their diet and lose a lot of weight, their cholesterol may still be high. So it's not about what you do or you don't do, okay? It's just it can happen and that's okay. And so for this, I personally think that statins, which are the cholesterol medications, they get a little bit of a bad press. But I do think it's important that you always discuss with your doctor if your cholesterol is high, to see if they think that you should be on a statin. And for example, in my practice for women that are young and that they're not, they're still kind of like it's not clear what their risks are. So things that make me feel like they should be on statins are if there's a family history of heart disease, especially if it was earlier in life, like if for example, parents or grandparents had a heart attack in their 40s or 50s. That's one of the things that, and if you had preeclampsia and if you had high cholesterol, it like starts alerting me that maybe you're a good candidate for a statin, right? If someone had, other risk factors, like if someone has diabetes, super good candidate for a statin. So definitely talk to your doctor because each case is different. And so you should 100% consider getting screened. And in that sense, seeing a preventive cardiologist may be helpful because a lot of the guidelines, believe it or not, the guidelines on cholesterol are different based on which specialty you have. And so cardiologists are the ones that tend to be more strict with cholesterol. And so I personally would, if you have the chance to see a preventive cardiologist, I would absolutely take it.
Tara, I think maybe that answered your question there. If your cholesterol is only a little high, should you consider a statin? It probably depends on the physician you're going to. So if you go see a cardiologist, they may, especially one who understands your risk after
Women's,
preeclampsia,
yeah,
um,
absolutely.
like Maria, depending on how elevated it is, even if it's just a little, maybe they would. So I think that is super great, a super great pro tip. And we always tell people like, cardiologists are the blood pressure specialist, right? You come out of that pregnancy and you're still having blood pressure problems after 6 weeks postpartum, and your doctors are trying you on a bunch of medications and it's not quite working, or we're seeing some I see people with what I think are probably not fantastically controlled blood pressures. Like, see if you can get in to see a cardiologist. They're going to be the ones that are, the
More strict.
exactly. But
Yes.
we'll get you what get you the regimen you need to be your best, healthiest self. So
Yeah. I have a question, Kara, because I do realize that we're close to 4. I can stay for a little bit more, but if not, you're
yeah,
fine. Because
absolutely.
I do want to get to the last slide because I see people asking like about the levels, and I have a slide kind of
Yeah,
summarizing
no,
everything.
no, yeah, I can. We're here as long as you are. So
Okay, I'll try to be a little faster.
no, it's okay.
All right, so now how to manage blood pressure. And so again, blood pressure is super important. You all probably know that there's two numbers. So it's usually written like this ratio. And so we read it, for example, 117 over 76. And so the top number is called the systolic blood pressure. And that is basically the pressure in your arteries when the heart is contracting. And the diastolic is the bottom number. And that's the pressure in your arteries when the heart is kind of resting, so in between contractions. And so a true normal blood pressure is lower than 120 over 80. Okay. And in my
Yeah, that's
practice,
like that's the big, news here, right? And we're telling people as well, like if you're 120 over 80, that used to be standard normal, right? And it's not. That's pre-hypertension, right? When you're 120 over
exactly.
80, you're pre-hypertension now. Go
Yeah.
ahead, sorry.
No, totally. And I feel very strongly about this because we know that the more controlled the blood pressure, the better, right? And women like you guys that are healthy, or most of you, I mean, there's people that cannot tolerate that much medications, and that's okay. You do what you can. But most women that are, after preeclampsia, they're able to tolerate medications to get to this goal. And so in my practice in particular, I'm very strict with blood pressure. Again, it changes based on the specialist that you see. But you can discuss with your doctor, what's a good goal for you. But the things that you can do to lower your blood pressure is definitely avoid nicotine. Weight loss, I see it all the time with my patients. Patients lose weight, they don't need the blood pressure medications.
I went from two blood pressure medications to perfectly normal blood pressures. My last blood pressure is like 110 over 57, just by losing the weight that I needed to lose. And I still have some that I could lose, but you're right. It can make a difference.
Yeah, it's a huge difference. And same for a lot of the medications that people are chronically. Once you lose weight, you just stop using them. And so that's why, a lot of people, a lot of my patients that get bariatric surgery, for example, it's crazy. Like their blood work just changes completely. And something to keep in mind. The other thing to keep in mind is that a high blood pressure is not going to kill you. Like, you know what I mean? If you get a read at home that is 160 over 90, like don't worry, like it's not an emergency, you don't need to go to the hospital. If you have symptoms, of course go to the hospital, but most of the time, blood pressure fluctuates, and it should fluctuate. Your blood pressure should go up if you're in pain, your blood pressure should go up if you're anxious, your blood pressure should go up if you're just returned from running or doing some physical activity. And so it also depends on how did you measure it. Did you wait 5 minutes relaxing in a chair while just so you can calm down, and then, measure it, make sure that you're not anxious at the time that you're measuring, make sure you don't have a headache, you know what I mean? So all those things are important. And again, don't obsess about the numbers. It's okay to have a high number every once in a while. It's more like the trend, right? If your blood pressure is consistently over 120 over 80 is when I get kind of, a little more strict with it. If it just once in a blue moon you have a high blood pressure, it's probably okay.
And I just want to point out that you said 160 over 90 is not an emergency. And we're talking about outside of pregnancy. So if you've got,
Yes,
for
yes.
160 over 110, you should get yourself to labor and delivery.
No, no,
But
absolutely. Yeah.
outside of
Pregnancy is a different
pregnancy,
story.
yeah, yeah. No, I just want to clarify that for anyone who joined in late.
No, no, good, good. Um, Less salt in the food definitely helps decreasing the blood pressure. Exercise, good sleep, lowering stress, easier said than done, but definitely helps. And obviously medications.
Yeah, I think
Um,
we don't have to do everything the hard way. And you kind of mentioned that earlier as well, right? If you need to get your cholesterol down, yes, you can, change your diet, you can exercise more. For some people, that will work. For others with genetic, history in their family, that may not be enough. We don't have to do all of this the hard way. And in fact, we can take the medications we need while we need them and work on those things where we can lower some of these things potentially, through those harder changes.
Absolutely. All right. Quitting tobacco. I know it's much less popular nowadays, but in case this is helpful to any of you, I thought it was important to talk about it anyway. Quitting smoking is probably one of the most powerful things a person can do for their health, but it's also super hard. And so, if quitting smoking was easy, like everybody would do it, right? Like it's clear that people like know that this is not good for your health. So this is not about being strong enough. It's about finding, again, the right tools for you and the right support for you. And so even if you've tried before and you have started smoking again, that's okay. You can try again. So some things that you should know is that, within a year, only within a year after quitting, your risk of heart disease already decreases by half. That's huge. And then some things that you can kind of think about on how to avoid smoking is like know your triggers, right? Like if stress is a trigger for you, then think about, okay, what am I going to do when I'm stressed out before you get stressed out? What am I going to do if I get stressed out? Instead of smoking, maybe I'll chew some gum. Maybe I'll do some deep breathing. Maybe I'll go for a quick walk. So just have a plan in your mind of like, what am I going to do if I get stressed out and I get the trigger, that I know for a fact is going to make me want to smoke. Um, give yourself a reward, right? Like if you reach a milestone, if you're like, okay, I've been a week without smoking, this is the time to celebrate. Get a burger, you know what I mean? Like that's fine. Like smoking is so bad that like give yourself a reward. You can eat anything you want for that
Does
reward.
this cover like e-cigarette as well? Does that have
Yeah.
quitting e-cigarettes? Are there risks there as well?
Yes, definitely. We know a little bit less. We do know it's not great. If I had to choose between smoking tobacco versus e-cigarette, I'll probably go with e-cigarette, but definitely the most important would be not smoking at all.
Yep.
Same with like I get this question a lot, even from my own family members, like, oh, I love Coke, then drink Diet Coke, you know what I mean? Like,
Yeah.
is Diet Coke super healthy? Probably not, but it's definitely healthier than regular Coke.
Right.
So, you know what I mean? Do what you can. And then in case you guys, this is helpful to you, these are some free kind of quit lines and text programs you can use. Also, definitely involve your physician. Everybody, we get trained about how to make sure that to help people quitting, there's medications, there's a lot of things that you can try. So definitely, talk to your doctor about it. You don't have to do it alone. All right. Now, healthy sleep. So most of us know that sleeping is very important, but between work and family and stress and screens, it just feels almost impossible. And so, again, if you recently had a baby, you're also in survival mode. So like sleep may feel completely out of your control, and that's okay. Again, we're playing the long game. So it's about finding small ways to rest and recharge, right? And so if you just had a baby, this is temporary. Your sleep will regulate at some point. So just have some patience and then take some short naps whenever you can. If you can sleep, then you should definitely try some kind of sleep hygiene techniques that can help you. Some people have issues, for example, falling asleep or staying asleep, and so. For example, trying to set up alarms to like remind you of your bedtime, because people kind of forget that they start watching TV and they kind of get it or looking at their phones, and
Now it's
so just
12
have
hours in and it's 2
yeah,
in the
it's
morning.
what
Yeah.
am I doing here? And so set up an alarm so it reminds you that you should go to bed. If you are watching TV or if you are on your phone, it's important if you can dim your screen or use the red filter. Most phones have it because the bright blue light that screens have can kind of mess with your circadian rhythm. So it's important if you can to switch the filter of the lighting. You can Google how to do it. Most devices you will be able to do it super easily. If you like coffee, like me, then set up a time that you stop drinking coffee. So for example, for me, it's at 3 p.m. I just don't drink more coffee after 3 p.m. Even if I have zero issues falling asleep, I fall asleep anywhere, but I don't know, it's unknown if caffeine can affect your sleep quality, right? So then for me, I just decided that after 3 p.m., I'm not going to drink any more coffee. If you are someone that struggles with falling asleep, maybe that should be noon to you. Um, Definitely alcohol also can affect your sleep. So if you can avoid that, that would be great. A bedroom that is cool and dark and quiet can help with your sleep quality as well. And so all of these like little tips can help you have some, some good sleep. It is recommended that people sleep within around 7 to 9 hours per night. And so you can try your best, but super important. And I mean,
Right. And
nice to do.
if you can get 6 hours instead of 5, you're doing, that's baby steps in the right direction.
Exactly. All right, so almost done. And so
No,
now that I have
but
preeclampsia, what should I do? Summary. So again, if you just had a baby, give yourself some time and patience and think about your next steps when things settle. Get
yeah.
regular blood pressure checks.
And that's probably not, things aren't going to be settled in 3 days or 3 weeks, right? It's
We're
going,
talking months, even years sometimes,
right.
and that's okay.
Yeah.
Get regular blood pressure checks. So for someone like you guys that, most of all of you had some sort of hypertensive disorders of pregnancy, I would have my own blood pressure cuff. I'm sure most of you do. And I would just check my blood pressure every now and then and just log it, have a log of it. And then when you go to the doctor, just, you know kind of what your pattern is, you can show them. And if you are on medications, they can titrate your medications based on it. In my practice, I actually value more the blood pressures that people take at home rather than the ones that I take in the office, because in the office, people are anxious and like, just like, people don't like to go to the doctor. I get it. And so their blood pressure may be high. So, in my opinion, home blood pressures are more important. And so, definitely, and that's something that you can do yourself. So, you don't need anyone else. So definitely regularly check your blood pressure. Also, don't obsess about it. You don't have to do it every day, but a couple times a week and log it in at different times of the day. And then so you can kind of find patterns in case some of your blood pressure numbers are high. Monitor for blood sugar. So screening for diabetes is important. And so go ask your primary care doctor to screen you for diabetes and cholesterol, ask your primary care doctor, hey, can you refer me to a preventive cardiologist? Because preventive cardiologists can do other things. Like, for example, we also check for this thing called LP little a that some of you may have heard about, but it's basically a subset of the bad cholesterol that is absolutely genetically mediated. So, and there's really no way to lower it right now, although there are clinical trials that have medications that will most likely, we will have medications in the next few years for elevated LP little a, which is how we call this. But even just checking it, for example, you know how we were talking about how if someone had preeclampsia and they have a family history, they have other risk factors. If they have, in addition, they have an elevated Lp(a), I absolutely put them on statins, 100%, because it's just it really increases your risk of heart disease. And so know your numbers. What is your ideal blood pressure? We talk about that for not pregnant women, and this is for all non-pregnant women, because in pregnancy, all of these changes.
Right.
But for non-pregnant women, less than 120/80. What is your ideal LDL? Less than 100 at least. In my preference, if people are at high risk, like for example, the case that I just told you about, someone that has family history, elevated Lp(a), had preeclampsia, I actually like it less than 70. And even for someone that already has heart disease, less than 55. So it gets stricter with time. Again, this is all depending on who's your doctor. If you go to a primary care doctor, their primary care guidelines don't say that you should have your cholesterol less than 100. So that's the reason, like, it's not like your doctor is mean or doesn't want to help you. It's just everybody kind of does what they can do best. And so the primary care guidelines are different. And so that's why, going to a cardiologist may be beneficial in that sense. Ideal glucose less than 100 if it's just fasting glucose. I like hemoglobin A1C better for screening for diabetes or sugar because it gives you the average of 3 months. You don't even have to be fasting, so when you check it, but it gives you an average of 3 months. Um, what is your ideal BMI? 18.5 to 25 is technically the ideal BMI. And you can calculate that yourself. Go on Google and put BMI calculator, and it just literally takes your weight and your height, and that's how you can calculate it.
And BMI, like, which I found just personally, you don't have to get to that ideal weight to reduce your risk factors and to maybe even come off of some of your medications and things like that. Even small changes can sometimes make a big difference in your numbers, as we strive for that, ideal.
Definitely. Um, as we talked about before, make small and sustainable lifestyle changes. Diet, short works count for exercise. You don't need to go to the gym, do a extreme workout. Prioritize sleep, stress management, get support. You don't need to do any of these alone. Even if you have sleep issues, a lot of people have sleep issues. Go to a sleep doctor. There's sleep medicine doctors, there's weight management doctors, there's endocrinologists, there's cardiologists, there's a lot of people that you can go for help. And give yourself some grace. Like it's a journey and it's not a race, right? It's not all at the end, all you want is to improve your health at long term, right? All right, and then two more questions that I had that kind
Or
of I know that they were a lot of people had this question, and so is what should I do before I get pregnant again, and what should I do if I am pregnant again? So what should I do if I get pregnant again before I get pregnant again? I highly recommend you to have a preconception counseling. It can be with if you don't have a good primary care doctor that kind of knows a lot about, women's health. You can do it with your MFM, you can do it with your OBGYN. Those are great because basically it's just analyzing what your risk factors are, and then you know what kind of what you can modify and what you cannot modify. Optimize your risk factors as much as possible. So if you have high blood pressure, make sure that your blood pressure is well controlled before you start your pregnancy. Get tested for diabetes and cholesterol. And if you have high cholesterol and you're not going to get pregnant right now, consider getting a statin if you are at higher risk. Aim for a healthy weight if possible. Again, losing weight is hard. We all know it, but studies have shown that if you start your pregnancy on a healthy weight, you have lower risk of complications. And then eat healthy and stay active. And then the one last thing is, most of you probably have heard is baby aspirin. You can consider a baby aspirin at the time of your pregnancy. We usually don't start it before 12 weeks. Anyway, so you even if you're pregnant already, you have time to sort of talk to your doctor about it. But baby aspirin, or the 81 milligram aspirin, has been shown to reduce your risk of preeclampsia. It's a very small reduction, so don't think, it's not like if you take baby aspirin, you're not going to have preeclampsia, but again, everything kind of adds up, right? All right, so what if, I just got pregnant again. I didn't have time to do the preconception counseling. That's okay. We'll just manage the way we can. So again, consider a baby aspirin. You can ask your doctor. Chances are that if you already had preeclampsia, your MFM will put you on a baby aspirin at 12 weeks or after 12 weeks. Manage blood pressure if elevated, and the earlier is the better. So the cutoff for pregnancy is more than 140/90. It is possible that this may change in the future. We just, there's not enough studies to show that a lower cutoff is better, but I suspect that there will be in the future.
actually,
But for now,
they're working on it right now. I know there's a committee that's looking at blood pressures in pregnancy to determine if they're going to make that, an adjustment to the,
which, yes,
yeah. So it'll be interesting in the next couple of
it'll
years.
be interesting. Yeah, I agree. Calcium, a lot of, if you Google something, I wanted to put this in here so you don't worry about it, but calcium has been shown to be beneficial for preventing preeclampsia. But in the US, like even if you have the worst diet, it's very hard to not meet the daily requirements of calcium. So that's why calcium supplementation is not recommended. Because technically the daily target it's like 1,000 milligrams a day, but even 500 milligrams a day, it's probably enough. And again, a lot of things have calcium, so even things that you don't think about. So it's very, very rare that somebody doesn't meet this daily sort of, calcium dose.
If your doctor
Mediterranean,
and if your doctor's recommended it, then that's fine, right? And if you're
that's
not
fine. Yeah,
West, you may have a different risk. We had somebody post
exactly.
about calcium this week in the group about how they wished it was a mandatory requirement to prescribe calcium, and the fact is that even supplementation doesn't necessarily reduce that preeclampsia risk. For some individuals, it certainly does. So just follow your doctor's direction, but otherwise, no need to supplement.
Yeah, correct. Another thing that I don't think people know is that actually Mediterranean diet during pregnancy can decrease the odds of developing preeclampsia as high as by 30%. And so this was a study that basically looked into scores of adherence to Mediterranean diet, and the women that adhere most to Mediterranean diet had a decreased risk in preeclampsia. Compared to the ones that didn't adhere to Mediterranean diet recommendations. So this is something that you can actively do while you're pregnant. And then also exercise. This particular study showed that 140 minutes per week can decrease the risk of preeclampsia by 40%. But, even maybe a little, if you cannot do 140 minutes per week, because exercise while pregnant is hard. It's hard, even harder than when you're not pregnant. So even just whatever you can do, it's probably beneficial in terms of decreasing your preeclampsia risk.
And
What is a lot of one question is like, what is moderate intensity? Like, what does that mean? Moderate intensity is like brisk walking, biking, dancing, gardening, playing tennis, playing tennis for like normal people, like athletes, obviously it's like in severe intensity, but
is
if
there
it's
like a heart,
leisure,
is there like a
some.
heart rate that's we should be looking out to hit?
Yeah, technically, so your target heart rate should be 220 minus your age.
Okay.
Um, but this obviously changes depending on your medical conditions. But
Sure.
for most
Healthy.
healthy young women, 220 minus your age should be a good target for you. Um, yeah, even household chores can be physical activity depending on, what you do. Active yoga or Pilates, things that you can do during pregnancy, everything will help.
Yeah.
But
I get
yeah, that was all I had. So in case you had any questions, happy to answer.
Yeah, and I just want to the reduction percentages don't those aren't necessarily in an individual basis. So you
Correct.
not reduce your own individual risk by 30 or 40% or cumulatively. It's like a population study. So just like aspirin is recommended fairly widely, there's approximately a 15% reduction
Hmm.
preeclampsia with low dose aspirin. That obviously means, lots of people still get preeclampsia even though they took aspirin, right? But we never really know what's going to work for you. So incorporating, the things that you can, all are baby steps in the right direction. So.
Definitely.
Fantastic. Okay. I think you did answer almost all of the questions that we had come in or that have popped up along the day here. Um, so you mentioned the Mediterranean diet. Oh, one that I don't think we touched on, and I don't know that if this is your area of expertise. So if it's not, that's okay. But we had a question about perimenopause and menopause, but also estrogen-based birth control. If you have had preeclampsia and or if you had preeclampsia and now you have chronic hypertension, do you as a cardiologist make recommendations on
Yeah, definitely.
estrogen-based birth control and also like I would guess like hormone replacement therapies for those of us who are going to be in that?
Yeah, hormone replacement therapy is a little trickier
Okay, okay.
because I think there's still a lot that we need to understand. I think that there was a time that, there was one study that showed that it could potentially increase the risk of breast cancer, but it has been severely criticized. And so I think in the next few years, we will have sort of better recommendations on how to treat perimenopausal women or menopausal women, because I do think that probably some menopausal women should have hormone replacement therapy. And it's just a matter of like defining that population, like who benefits from hormone replacement therapy versus the ones that maybe we shouldn't do it. So I think that there's more to come. There's definitely a lot of research being done in that field too. But in terms of anti-contraception, I do, if you have high blood pressure or heart disease, in general, I do recommend progesterone-based anti-contraception, or, like something non-hormonal, like, there's an IUD that is the copper IUD, that has no hormones. But in general, progesterone is fine. Because even, and some of you may know, may have experienced this, but some women, even before they have preeclampsia and pregnancy, some women, even just taking oral contraception pills, they can have a little bit of high blood pressure. And so we know it definitely affects, somehow affects the vasculature. So, if you have high blood pressure and if you have heart disease, I recommend either progesterone-based or non-hormonal methods.
And then one thing I just wanted to mention, I know we have a lot of our members who will be on antihypertensive medications either during pregnancy or postpartum to control their blood pressures. And they have maybe a lot of side effects because they're older, of course, safe pregnancy medications. And I often tell them, just because I've had my own personal experience with this, that once they're done like breastfeeding, their options for medications open up significantly to like more sophisticated, like modern medications. And coming to a preventative cardiologist is the potentially the way to get on that therapy that is maybe easier once a day to take, that controls better without a lot of the side effects. And I hope I'm telling them that correctly. Rather
No,
than,
it's totally true. It's
yeah.
totally true. Yeah, I think that's another thing that, obviously if you want to breastfeed as much as you want, and like we'll work around it. That's fine. But some of my patients are like, you know what, I'm done. I'm done breastfeeding, and that's also okay. Like you don't have to breastfeed for the same time that other people do. You do you. So, yes, if in pregnancy, most of you probably, or postpartum, if you're breastfeeding, most of you are taking either nifedipine or labetalol, or hydralazine. Others that are less used are like things like enalapril and captopril that are also breastfeeding safe. And then one of them that I use when I have issues controlling blood pressure is spironolactone, that is also breastfeeding safe. And, it has potentially other beneficial effects that we're actually hopefully studying. Actually, Kara and some of you actually helped us with some ideas for a clinical trial that we're proposing right now, to use spironolactone in the postpartum hypertension patients. So, but once you're done breastfeeding, like there's like
So
so many options, so many options.
yeah, and it doesn't have to feel so overwhelming. You're not having to take two or three different medications 4 or 5 times a day. You can maybe take once a day or twice a day and have something that works so much better. So I just like to mention that and to get your feedback on it because we have so many members who are, they were perfectly healthy. They had these pregnancies. They experienced whatever sort of endothelial damage that they had, and now they've got, chronic hypertension and are, just sort of bummed that now they're on medication, essentially, potentially, for the rest of their lives. And it doesn't have to be so sort of all-encompassing like it can be during pregnancy when you're taking those older, safer medications, which require more dosing and sometimes multiple medications. So I just wanted to put a plug in for that it's not the end of the world if 50% of us walk out of these pregnancies with chronic hypertension. It's not so bad necessarily on the other side when you get there. If that's what you need to do to keep your heart healthy, is take medication. Find a great preventative cardiologist. Get that referral if you can to get to the experts on blood pressure and medication, so that you can sort of have an easier time at that. And
Yes.
the last question is because we just talked about this recently. What's your personal thoughts around white coat hypertension being sort of a yellow flag for the development of chronic hypertension?
Yeah, we have data that we know that it is. And so, it is, so in my practice, I like home blood pressures much better. But if I know that somebody has white coat hypertension, I definitely tell them like you should monitor this at home. Like, you know,
Because at
sick,
some point, maybe in that, because I think you mentioned a 5 to 10 year range after, delivery, after preeclampsia is, when we start to see more of that cardiovascular
exactly.
disease. And
Yeah.
we have so many members who their blood pressures are fine within, a couple of like 2 weeks of delivery, and they're like, woohoo, this is great.
Hmm.
And then they go in, 6 months later for, a tooth cleaning or something like that, and they take their blood pressure and it's high, and they're like, what? It was perfectly fine 2 weeks postpartum. Well, you know, is it white coat hypertension? Is it, because of anxiety? And the answer is you want to flag it and watch it, right? Because there is data saying that white coat hypertension is maybe an early warning sign of chronic hypertension to come, later. So I just wanted to see what your
Definitely.
thoughts were.
And
Well,
yeah, and I wanted to say something because I just was just reading the chat and a lot of people are asking for the slides. I absolutely am happy to share them. So I'll send them to Kara and you can distribute.
yeah, we'll distribute them out with the link to the video for those of you who logged in and registered for the Zoom, and then we'll also post them in the group for those who are watching on the live stream. Thank you so, so much. I've got a list of like 5 other webinars we can have
Mm-hmm.
regarding uh, our heart health and different stages of life. But I hope this was really helpful. For some of the questions that I saw come through, I will, if we didn't answer them, I will try to gather some of those and maybe get some updates from Maria for those. But I think you did just a fantastic job answering all of these questions today. I really thank you so much for joining us, and for spending your time with us and going over time as well.
No, it's my pleasure. It's my pleasure. I love preeclampsia, as I told Kara. Yeah.
Thank
So
you.
anytime I can help, definitely available.
All right. Thank you so much. Have a great night. Thank you, everyone who
Bye.
joined. Um, we hope to be putting on some more webinars, I think, in the next month or two. The next conversation is going to be about that 6-week postpartum checkup, which I'm sure we'll talk about blood pressure then as well. Dr. Mark Santillan is going to fill us in for that. Have a great one. Enjoy the rest of your day or night, depending on where you're coming from. Good night.
Bye.
Bye.